Exercise response to IGFs. IGF-1 has been the primary IGF studied in the context of exercise due to its prolific role in protein anabolism. The exact reason for acute increases in blood levels of IGF-1 are unknown, but are probably related to the disruption of the various cells, including fat and muscle cells. Because these cells manufacture and store IGF, how acute changes occur with exercise is a bit of a mystery. As mentioned previously, it takes 8 to 29 hours for IGF to be produced following stimulation by growth hormone. This seems to indicate that IGF is released from storage sources other than the liver. That release is due to cellular disruption of cells that already contain IGF, or that growth hormone mediated release of IGF with certain types of exercise has a different time course from injection response studies. Systematic alterations in circulatory concentrations of IGF in response to various types of exercise protocols appear to be closely related to regulatory factors of IGF release and transport. Evaluation of serum changes over longer periods are necessary to evaluate specific effects and relationship of growth hormone in the serum. The endocrine and maybe paracrine release of mechanisms of IGF may be paramount in IGF-1 influence on muscle. Fat cells contain relatively high concentrations of IGF. Skeletal muscle has very little of its own. It is possible that IGF may release from non-hepatic cells without the mediation of growth hormone. In addition, cells may produce and keep IGF where they work without entering the peripheral circulation. Although IGF-1 has been shown responsive to exercise in some studies, it does not follow a class endocrine response, i.e. stimulus of gland by exercise resulting in hormone release into the blood. In all cases, it has been shown that IGF-1 was responsive to resistance exercise in men and women, but in those studies, the starting concentrations were lower. In another study, the concentrations were higher, and despite increases in immunoreactive 22-kDa growth hormone, no increase in IGF-1 was observed. From these studies, it has been theorized that the starting level of IGF-1 may be a factor in determining whether the increase observed with exercise, i.e. no increase if starting concentrations are high, and increase if starting concentrations are low. A study by Kramer et al. Supported this theory, but it was also shown that IGF-1 concentrations were more sensitive to acute caloric loads, which included carbohydrate and protein supplementation before and after a workout. Training adaptations of IGFs. Responses of IGF-1 to heavy resistance training remain unclear, but recent reports from the author's laboratory demonstrates that changes are based on the starting concentrations before training. Basal concentrations are low, IGF-1 increases. If high, there is no change, or it decreases. It is far too soon to judge what happens to the hormone with resistance training, yet this author's data for women show little or no change with training. As with growth hormone, training-induced adaptations in IGF-1 are probably reflected in a variety of mechanisms related to release, transport, and receptor interaction. Furthermore, the interaction with other anabolic hormones cannot be ignored as they are the target of the same outcome: protein synthesis. Adaptations to heavy resistance training of IGF-1 in the various tissue require further investigation. The adrenal hormones. The adrenal gland has two major divisions, the cortex and the medulla. Both divisions respond to exercise stress. The adrenal medulla is stimulated by the nervous system and thus provides the faster response. The cortex is stimulated by adrenocorticotropic hormone, adrenocorticotropic hormone, ACTH, from the anterior pituitary. The adrenal gland plays a crucial role in the fight or flight phenomenon. The adrenal hormones most important to training and conditioning are cortisol, a glucocorticoid from the adrenal cortex, the catecholamines from the adrenal medulla, and the enkephalin contain polypeptides. Peptide F. Peptide F, a proenkephalin fragment, plays an important role in enhancing immune cell function. Thus, the adrenal medulla also secretes hormones in the recovery from stress. Cortisol. In a classic sense, glucocorticoids, and more specifically cortisol in humans, have been viewed as catabolic hormones in skeletal muscle. In reality, however, cortisol is a primary signal hormone for carbohydrate metabolism and is related to glycogen stores in the muscle. When glycogen concentrations in the muscle are low, to gain energy, other substrates, proteins, need to be catabolized. The major catabolic effect of cortisol in muscle are as follows: converts amino acids to carbohydrates, increases levels of proteolytic enzymes that break down proteins, inhibits protein synthesis. It appears that cortisol may have greater catabolic effects on type 2 fibers because they have more protein than type 1 fibers, but it may be more involved with the control and degradation of type 1 fibers. As pointed out earlier in this chapter, type 1 fibers rely more on reducing degradation to develop muscle hypertrophy than dramatic increases in synthesis used by type 2 fibers to develop hypertrophy. In situations of disease, joint immobilization, or injury, an elevation of cortisol mediates a nitrogen wasting effect on the net loss of contractile protein. This results in muscle atrophy, with association reductions and force production capability. In the muscle, the anabolic effects of testosterone and insulin counter cortisol's catabolic effects. If a greater number of receptors are bound with insulin, or if testosterone blocks the genetic element in DNA for cortisol, protein is conserved, enhanced. Conversely, if a greater number of receptors are bound to cortisol, protein is degraded and lost. The balance of anabolic and catabolic activities in the muscle affects the protein contractile unit, directly influencing strength. The acute increases in circulatory cortisol following exercise also implicates acute inflammatory response mechanisms and tissue remodeling. Resistance exercise response of cortisol. As with growth hormone, it appears that cortisol increases with resistance exercise, most dramatically when rest periods are short and total volume high. As mentioned in the discussion on testosterone, increases may not have negative effects in men after a period of training to which the whole body is adaptive. Adaptation disinhibits cortisol at the level of the testes, thereby maintaining testosterone concentrations. Cortisol responds to resistance exercise protocols to create a dramatic stimulus to anaerobic metabolism. It is interesting that the acute exercise protocols that produce the highest catabolic response in the body also produce the greatest growth hormone response. Thus, though chronic high levels of cortisol may have adverse effects, acute increases may be part of a larger remodeling process in muscle tissue. Muscle must be disrupted to a certain extent, below injury levels, to remodel itself to enlarge. Acute elevations in cortisol would help in this process. Because of the catabolic role of cortisol, athletes and training professionals have much interest in the potential as a whole body marker of tissue breakdown. To a certain extent, cortisol is such a marker, but the magnitude of increases may need to be greater than 800 nanomoles per liter to indicate potential overtraining problems. The testosterone to cortisol ratio has been used to an attempt to determine the anabolic catabolic status of the body. Although such markers are attractive conceptually, serum cortisol measurements and testosterone to cortisol ratio have met with only limited success in predicting or monitoring changes in strength and power capabilities. Problems with these tests probably have to do with the multiple roles of cortisol and other hormones. It is probable that the vast differences are observed in the physiological role of cortisol in acute versus chronic exercise response to resistance exercise. Acute cortisol response may reflect the metabolic stress of the exercise, and chronic aspects may be primarily involved with tissue homeostasis involving protein metabolism. Thus, cortisol's role in overtraining, detraining, or injury may be critical when muscle tissue atrophy and decreases in force production capabilities are observed. Such roles remain to be demonstrated. However, cortisol's role in suppressing cells of the immune system, T cells, has a direct impact in the recovery and remodeling of skeletal muscle tissue. The connection to the endocrine and immune system is a vital link for resistance exercise adaptations and is just starting to be explored in the laboratory. Resistance exercise protocols that use a high volume, large muscle groups, and short rest periods result in increase in serum cortisol values. Although chronic high levels of cortisol may be adverse catabolic effects, acute increases may contribute to the remodeling of muscle tissue. Catecholamines. The catecholamines, primarily epinephrine, but also norepinephrine and dopamine, are secreted by the adrenal medulla and are important for the acute expression of strength and power because the hormones act as a central motor stimulators, peripheral vascular dilators, and enhanced enzyme system of muscle. Their role in growth-promoting actions in muscle tissue is less clear, but they act to stimulate other anabolic hormones. The physiological function of epinephrine and norepinephrine in muscle are these: increase force production via central mechanisms and increase metabolic enzyme activity, increase muscle contractile rate, increase blood pressure, increase energy availability, increase blood flow, augment secretion rates of other hormones such as testosterone. Catecholamines appear to reflect the acute demands and physical stress of resistance exercise protocols. A high-intensity 10 RM short rest, 10 to 60 seconds between sets and exercise, heavy resistance exercise routine, 10 exercises, 3 sets, typically used by bodybuilders to develop of strength and hypertrophy, was shown to maintain increased plasma norepinephrine and epinephrine and dopamine levels for 5 minutes into recovery. In addition, epinephrine has also been correlated to lactate concentrations with exercise stress. With the stress response in the classic fight or flight situation, epinephrine starts to cascade of events. Adrenal responses are not involved in the recovery responses until the stress is removed. Some specific endogenous opioid peptides, preonkephalins, are secreted by the adrenal medulla, and are impacted the immune system, which is critical in recovery from exercise. If training is not varied, continued stress keeps the adrenal gland engaged and recovery is delayed due to the secondary responses of cortisol and its negative effects on the immune system cells and protein structures. Training adaptations and catecholamines. Heavy resistance training has been shown to increase the ability of athletes to secrete greater amounts of epinephrine during maximal exercise. It has also been suggested that training reduces epinephrine response to a single bench press workout. Because epinephrine is involved in metabolic and control force production and response for mechanisms of other hormones such as testosterone, growth hormone, and IGF, stimulation of catecholamines is probably one of the first endocrine mechanisms to occur in response to resistance exercise. Training protocols must be varied to allow adrenal gland to engage in recovery process and prevent a secondary response of cortisol, which can have a negative effect on the immune system and protein structures. Other hormonal considerations. A host of different hormones are involved in the maintenance of normal body function and in the adaptive response of the body to resistance training. Although we might focus on one or two hormones for their role in a particular physiological function, other hormones actually create an optimal environment for the primary hormonal action to take place. Hormones such as insulin, thyroid hormones, and beta endorphin have been implicated in growth, repair, and exercise stress mechanisms. Unfortunately, few data is available concerning their responses and adaptations to resistance exercise or training. Owing to the relatively tight homeostatic control of both insulin and thyroid hormone secretion, chronic training adaptations in circulatory resting concentrations of these hormones would not be expected. Improvements in insulin resistance have been observed with resistance training. It is more likely that changes in 24-hour secretion rates, sensitivity of the receptors, and binding interactions would be affected. Pakarinen et al. Have demonstrated only slight, non-significant decreases in serum concentrations and total and free thyroxine, a thyroid hormone, after 20 weeks of strength training. Permissive effects of such hormones in metabolic control, amino acid synthesis, and augmentation of other hormone releases mechanisms are the essence of such interactions with resistance training. Conclusion. As we continue to study endocrine system and its interactions with the nervous system, the immune system, and the musculoskeletal system, we find that the function of these systems are truly integrated. Communication among the systems is accomplished with hormones and other peptides. For years, coaches and athletes have appreciated the importance of anabolic hormones to mediate changes in the body and help with the adaptive response to heavy resistance training. Whether trying to optimize a workout or avoid overtraining, the strength and conditioning professional must remember that the endocrine system plays a role. The goal of this chapter was to provide an initial glimpse into the complex but highly organized system that mediates the changes in the body with training.